Summary of recommendations when mother with COVID-19 is caring for infant interventions. Mother-infant contact. At birth. 1. Mothers should not be separated from their infants unless the mother is too sick to care for her baby. If the mother is unable to care for the infant, another competent family caregiver should be identified. 2. Mother and infant should be enabled to remain together while rooming in throughout the day and night and practice skin-to-skin contact, including kangaroo mother care, especially immediately after birth and during establishment of breastfeeding, whether they or their infants have suspected or confirmed COVID-19 virus infection. 3. Neonates born to mothers with suspected or confirmed COVID-19 should be breastfed within 1 hour of birth. Mothers should apply appropriate IPC. 4. Early and uninterrupted skin-to-skin contact between mothers and infants should be facilitated and encouraged as soon as possible after birth, while applying necessary measures for IPC. This applies also to infants who are born preterm or low birth weight. 5. If the newborn or infant is ill and requires specialist care, such as neonatal unit, arrangements should be made to allow the mother free access to the unit, with appropriate IPC measures. 6. Earlier initiation of breastfeeding results in greater benefits. Mothers who give birth by cesarean section, after an anesthetic, or those who have medical instability that precludes initiation of breastfeeding within the first hour after birth. During early childhood. 1. Infants should be breastfed exclusively during the first 6 months after birth, as breast milk provides all the nutrients and fluids they need. 2. From 6 months of age, breast milk should be complemented with a variety of adequate, safe and nutrient-dense foods. Breastfeeding should continue up to 2 years of age or beyond. 3. Breastfeeding counseling, basic psychosocial support and practical feeding support should be provided to all pregnant women and mothers with infants and young children if they or their infants and young children have suspected or confirmed COVID-19 infection. If feeding is interrupted. 1. In situations when severe illness in a mother prevents her from caring for her infant or prevents her from continuing direct breastfeeding, mothers should be encouraged and supported to express milk, and the breast milk provided safely to the infant, while applying appropriate IPC measures. 2. In the event that the mother is too unwell to breastfeed or express breast milk, explore the viability of feeding with donor human milk. If this is not possible, consider wet nursing, defined as another woman breastfeeds the child, or appropriate breast milk substitutes, informed by feasibility, safety, sustainability, cultural context, acceptability to mother and service availability. 3. Mothers who are not able to initiate breastfeeding during the first hour after delivery should still be supported to breastfeed as soon as they are able. Assistance should be provided after recovery for relactatio to re-establish a milk supply and continue breastfeeding. Best practices for breastfeeding. 1. Health facilities providing maternity and newborn services should enable a mother to breastfeed for as often and for as long as she wishes. Minimizing disruption to breastfeeding will require health care practices that enable a mother to breastfeed. 2. All mothers should receive practical support to enable them to initiate and establish breastfeeding and manage common breastfeeding difficulties. This support should be provided by appropriately trained healthcare professionals and community-based lay and peer breastfeeding counselors. 3. There should be no promotion of breast milk substitutes, feeding bottles and teats, pacifiers or dummies in any part of facilities providing maternity and newborn services, or by any of the staff. Health facilities and their staff should not give feeding bottles and teats or other products that are within the scope of the International Code of Marketing of Breast Milk Substitutes and its subsequent related WHA resolutions, to infants. 4. If the mother is too unwell to breastfeed or express breast milk, explore the best alternatives to breastfeeding a newborn or young infant, in priority order, as follows. 1. Donor human milk should be fed if available from a human milk bank. 2. If supplies are limited, priorities donor human milk for preterm and low birth weight newborns. 3. Wet nursing may be an option depending on acceptability to mothers and families, availability of wet nurses and services to support mothers and wet nurses. COVID-19 testing of a woman who is a potential wet nurse is not required. Priorities wet nurses for the youngest infants. In settings where HIV is prevalent, prospective wet nurses should undergo HIV counseling and rapid testing where available. In the absence of testing, if feasible, undertake HIV risk assessment. If HIV risk assessment or counseling is not possible, facilitate and support wet nursing. 4. Breast milk substitutes may be used as a last resort. This document is the update of an interim guidance originally published under the title Clinical Management of Severe Acute Respiratory Infection, SARI, when COVID-19 disease is suspected on March 13, 2020 of WHO.